Hi, everybody. I'm Raj Mago. I'm the editor of Simple and Practical Medical Education. And we are honored to have with us Dr. Joseph Goldberg. Uh, Today is March 30th, which is World Bipolar Day. Dr. Goldberg is internationally recognized as an expert in the field of bipolar disorder. Thank you, Dr. Goldberg, for speaking to us.
Oh, thank you, Raj, for having me.
So, just if you could say a few words about yourself, like how long have you been interested in the field of bipolar disorder? How did you get interested?
Years ago, when I was in college, I was working in a research group that was studying schizophrenia. The bipolar patients were the comparison group. And back then, we didn't have many treatments, and there was very little interest in studying bipolar patients. And I didn't have very good elbows for the schizophrenia researchers to push my way ahead. So I began interest in studying the comparison group. And over the last decades, there's been so much emergence of information about diagnostics, new treatments, not just about the illness itself, but its genetics, its cognition, its psychosocial consequences. So that really opened the door for me. I actually went to medical school to become a research psychiatrist because of that initial work back when I was in college.
Wow, that's quite unusual. And in you're also a clinician. You see patients. Are your patients mainly those with bipolar disorder?
Mainly I see patients for second opinion consultations with bipolar disorder. And part of what's intriguing to me as a clinician, as much as a researcher, is there's so much heterogeneity and variability in how patients present. So really, it's a chance for a clinician to focus on accuracy of diagnosis, affirming suspicions, evaluating comorbidities, looking at reasons why a first-line medicine might not work, or how a complicated regimen may or may not make sense. So it's actually quite the broad range of clinical challenges that come before us. And it also informs research questions, right? So you and I both might say we've seen a patient with a certain presentation. It inspires us to ask a research question, and then we go out and look it up. So it kind of keeps the scientific mind alive too.
Great, great. It's great that clinical work and research going together, which is not always the case. So I think that's wonderful. So why do we need Dr. Goldberg, a World Bipolar Day? Why is the problem of bipolar disorder so important that we are trying to focus the world's attention today on this illness?
Well, for many years, it was an under-recognized phenomenon. It was sort of molded together just with all of mood disorders and depression. And then in 1980, when the DSM-3 came along, the notion of polarity emerged as a distinction from unipolar patients. And in that year also, there was a great distinction of bipolar disorder from schizophrenia, which prior to then, there was more controversy about differential diagnostics, especially in the United States versus abroad. And in the ensuing years, the study of bipolar disorder has really constructed, I think, more of a clear impression that this is a heterogeneous disorder that's different from primary psychotic disorders, that's different from unipolar depression, that's different from people with personality disorders or substance use disorders, and yet it can encompass so many of the aspects of other areas we see that those of us who devoted our careers to studying this ailment, I think, have come to appreciate. It's complex, it's challenging, it has really unique treatments. Certain patients respond well to certain medicines based on their clinical profiles. Others respond better to other kinds of medicines. So it's sort of a delight to see that this entity has sort of gained its own gravitas as a phenomenon that we want to distinguish from lookalike phenomena, that we want to identify the specific, appropriate, and evidence-based treatments for, and to prognosticate for patients. This is not a negative prognostic disorder that has a deteriorating course if it's treated properly, if it's identified early on and correctly. So in some ways, the good news when we can catch a first episode of mania and minimize complexities and comorbidities and complications is to say, you may never have a second episode again if we can treat it right.
So if a person with bipolar disorder gets to a good psychiatrist and gets treatment, what would be the best case scenario? What are like, it's not a death sentence, or it doesn't mean this person is going to have a terrible outcome, does it?
Yeah, I like to say to patients, I stole a line from Donald Klein, the famous psychopharmacologist, used to say to patients something like, if all goes well, you won't see me much. And I tell patients, my hope is to fade into the background, is to come in, I spend a lot of time on initial diagnosis, a lot of time. And one message I would impart to clinicians or patients is devote copious time to the initial assessment. It will pay its dividends on the back end. So this is not a name that tune in 7 notes kind of condition. We have screeners out there, which are often brief and helpful screeners to get you sort of pointed in the direction.
Yeah.
But one might spend hours going through history, symptoms, family history, course of illness, treatment response, and everybody is exhausted by the end of a comprehensive assessment, but you've laid groundwork now at this point. So I can tell you, I think this is the right diagnosis or the right subtype. This is or is not rapid cycling. This is or is not bipolar 2 disorder. This is or is not lithium responsive illness, to frame the outlook for what comes ahead. If we can pin down the phenotype, the characteristics and the features, and try to match the right treatment to the phenomenology we see, the prognosis can be excellent. In my experience, it is less excellent when years go by with either no treatment, untreated illnesses like untreated infections or untreated malignancies. They don't get better on their own. And if you believe in the notion of kindling, more episodes trigger more episodes, or people get the wrong diagnosis, or an incomplete.
How common is that? How common is it that they get that people with bipolar disorder are not correctly diagnosed?
So it's interesting because there's a bit of an epoch issue here. We know from studies, say from the National Depressive and Manic Depressive Association, now the DBSA, years ago, the self-rated surveys patients filled out would talk about going 10 years from the onset of symptoms till an actual diagnosis. And in those ensuing years, since that study first came out, there's been an awful lot of awareness raised about bipolar disorder. And colleagues of ours now write papers on, is it overdiagnosed, is it underdiagnosed? So I think that it's on the radar and it's a level of awareness, but I think the challenge is rigorous diagnosis, because not everyone who sneezes has a cold, not everybody who coughs has pneumonia, not everybody who has mood swings has bipolar disorder. So really to fine tune the diagnosis requires this time. Someone who's floridly manic, it's one of the easiest diagnoses to make. It takes 4 seconds. It had the best reliability in the DSM field trials. Bipolar 2 disorder or incomplete presentations or unspecified presentations or cyclothymic disorder is much harder to get a clear fix on. So some of the lag time of diagnostics, I think, depends in part on how clearly defined the highs are, how predominant the lows are, and how carefully the history has been.
But on the whole, would you agree that this is still a big problem, that bipolar disorder, that people with bipolar disorder are not correctly diagnosed for several years? That's pretty commonly we see that. Would you agree?
Over the years, I think I've seen somewhat of a shift from what you just said to now. I see people coming out of the hospital. I see people who have an initial encounter without, a brief assessment rather than something more detailed. So I think it's on people's radar more. And I think it does go both ways. People like Mark Zimmerman have written about sort of hasty diagnoses.
The opposite, so people who don't have bipolar disorder are being called to have bipolar disorder.
And it involves, the failure to sit down with the rigor that's required to go through all the symptoms and the history, or I saw somebody recently at age 70 with no psychiatric history who said, their doctor thought they were bipolar, and you don't get new bipolar at age 70, but you may have something else, right? So it becomes a challenge, I think, because public awareness has risen over the last 10 to 15 years. The job of mental health clinicians and experts is really to come in and affirm. It is still underdiagnosed. I think it is also overdiagnosed. And I think it is also casually diagnosed. Yeah.
Both at the same time.
All the above.
Who have bipolar disorder are not being diagnosed, some of them, and then some who don't have bipolar disorder are being wrongly called. So like you said, going to a good psychiatrist who has experience and can correctly diagnose is probably the most important thing. Right. Now, what would be, so if bipolar disorder is not properly diagnosed and treated, what are some of the bad outcomes that can occur and because of which we are trying to raise awareness about this
Well,
illness.
certainly at its worst is suicide. People with bipolar illness are 30 times more likely than the general population to die by suicide or to make suicide attempts. Their standardized mortality ratios are more than double the general population, so they may not get good medical care. They often have medical comorbidities. 80% of them smoke. Their lives can become quite wrecked. 80% of marriages end in divorce. People lose jobs. They become geographically promiscuous. It's hard to take rooting. So for lots of reasons, it remains the number 6 cause of disability in the world. And people with this illness on average will lose 10 to 14 years of life expectancy. So the stakes are high if we miss it or if we can't make every effort to properly treat it.
On the other hand, like if it is properly treated, we do see people like they can really have a normal life, potentially like be doctors, lawyers, engineers, anything, right?
Yes, I mean, I think in some ways this is almost one of the key distinctions from illnesses we might think of as more neurodegenerative or deteriorative, and that's not an inevitability. My colleagues and I in Chicago have done 20-year follow-up studies on cognition, for example, and found that there's not a clear deterioration over time where there may be in more primary psychotic disorders. So I think there's so many modifiable factors. If you've had multiple depressions over those 20 years, you'll be in poorer shape than if your first episode was properly caught, and recurrent episodes probably have some psychotoxic effect on the brain. They certainly don't help your psychosocial functioning. Your family and your boss is less forgiving after your third event. So really the key issue is to catch this as early as possible to forestall or minimize the morbidity that might otherwise come from repeated episodes.
So your message to clinicians was to focus on the evaluation and to really not and to take the time that is needed to go into all the details. That's probably the most important thing that clinicians need to do, you said.
I put it on a sort of a tiering effect. So if you're not a subspecialist, but you're just a mental health clinician, you want to be alert to it. So if somebody comes to you with marital problems or substance use or anger issues, don't automatically assume a diagnosis, but probe, evaluate. Every depressed patient should be evaluated for a history of mania or hypomania. Someone who comes to you and says, I just quit my job and ran off and did something, any clinician needs to be aware this could be a tip-off. I need to screen and evaluate. And if you're not sure, it means scheduling a longer visit. It means saying, this could, here's my differential diagnosis, which could include bipolar disorder. But unless someone is floridly manic, they're in the emergency room screaming and expansive and so on, it may be a very detailed and highly worthwhile endeavor to sit down, speak with a collateral historian, get old records, start from the beginning. When I sit with patients, I say, so let's start from the beginning. Before you were born, what was the pregnancy like? What was the context? Any exposures, milestones growing up, expectable age and onset? How was adolescence, young adulthood? These are the high-risk times. Knowing that terrain, that territory, helps us to affirm suspicions and test hypotheses, so we can say to the patient at the end, this is what I think, and here's the basis for my conclusion.
Very nice. Very nice. What about like pay for patients? Like, what would be your message to patients? Like, what do you want patients to do differently than what a lot of patients are doing currently?
If you've been diagnosed with this condition, learn about it, the same as you would any condition. If you get diagnosed with anemia or Lyme disease or COVID or anything, yes, diabetes, you want to become an expert. So I have my reading list for patients, things from David Miklowitz's wonderful bipolar disorder survival guide to some of Kay Jamison's work. There's other resources we want to make patients aware of. We want to dispel myths. This illness does not mean your moods change from second to second to second. That's not what this illness is about. It's about episodes, not moment-to-moment shifts. You want to learn about what makes the illness better and worse, how to protect your sleep, the effect of alcohol and substances, the potential hazards of antidepressants, especially if used alone, may not be helpful, may have some potential to trigger more episodes in the short or the long run. The role of stress, circadian rhythms. So this illness really requires reading the instruction book and not a light once over, probably several once overs to really become experts so that patients will know. I can think of a physician I treat who was applying for residency and was very concerned about overnight shift calls and sleep-wake cycle disruptions, and had to get in touch with the disabilities office, the same as if he was in a wheelchair and couldn't use the stairs. So knowing what accommodations will be necessary.
This was a physician who had bipolar disorder himself.
Yes, yes, doctors are not immune. Doctors, lawyers, famous leaders in history. Nasir Gami has a wonderful book on talking about famous leaders and the ways in which people with bipolar disorder often are high creativity, high IQ, high associative fluency, high strivings, which is a double-edged sword. One can have high strivings, but if one hits life failures, the falls become hard. So being in good treatment, I think having a trusted practitioner is really critical.
Right. Okay. So for clinicians, we said like a thorough and proper evaluation is probably the most important thing for patients to educate themselves. And we'll put a link to these recommended resources for patients. We also, Simple and Practical has also recommended the Bipolar Disorder Survival Guide as probably the best book for patients to read, and others will link to them along with this video. What about for family members? Like, is there a message that you have for family members? What would you want them to do with regard
Yeah,
to
they need the
that?
same education because you don't cause bipolar, you don't make somebody else have bipolar illness, but you can identify features that might aggravate it. For instance, Dr. Miklowitz talks about high expressed emotion, and negative communication styles can create home environments that might be disruptive to mood stability. Someone who really needs to protect their sleep-wake cycle can't be asked to do an overnight trip, and the family has to sort of understand the ways in which the illness plays a role. If everybody's going to go out drinking, that might not be you. If your loved one had a peanut allergy, you're not going to say, let's all go to the Planters factory together.
Right.
So the family, I think, has to understand what the illness does and doesn't present, and also how to have sort of lines of communication. People talk about advanced care directives in a way, or psychiatric advanced care directives. If there comes a point where my decision-making becomes impaired, Kay Jamison talks about this, I've appointed you my healthcare proxy. Here are my wishes in advance of what I might like done in terms of treatment. What if I refuse treatment? What if I'm not adherent with treatment? This is a tremendous issue in bipolar disorder. Family members don't get very far by chastising the patient. You're off your medicines again, or threats like, we're going to throw you in the hospital. So it really has to be a cooperative endeavor of empathizing with the plight, saying, yeah, people can sometimes want to stop their medicines. It's important to talk to your doctor about it. If you're having side effects, there are wonderful books on how to manage side effects, one by you, another by me, another, and strategies and tools. So I think we want to help families and patients alike understand that this is a manageable, sometimes lifelong, but often manageable condition. And if the stars are aligned, it'll be quiet in its management for years to come.
Thank you so much, Dr. Goldberg. I think on this World Bipolar Day, clinicians, patients, family members, we should all come together and kind of resolve that we are going to do a better job of correctly diagnosing and evaluating this illness, helping patients to stay on their medication so that they can have happy lives and live up to their full potential. Thank you again.
Thank you for doing this program, Raj. Really appreciate it.